Okay, so let's go ahead and get started. Thank you so much, everyone, for joining us today to attend our opening lunch. We appreciate you being here so much. My name is Tim Montgomery, and I am the Director of Student Disability Services. I also want to take a quick moment and thank all of our participants who volunteered to share their stories for this project, all of our panelists today for sharing their expertise. And I also want to thank Kim Lapine for her amazing and tireless work behind the scenes for making the website, the participant profiles, and today's event happen. And I also want to give a huge shout out to ACS Captions. I think they're a little bit delayed in coming on, and we do apologize for that. They will be on shortly, hopefully, but if not, we will certainly have it captioned when the recording gets posted. And we, again, sincerely apologize for that. Once again, please feel free to submit questions in the chat box, and we will be addressing those at the end of the presentation. The Committee on Disability Inclusion, in collaboration with the Department of Psychiatry and Behavioral Sciences and the School of Medicine, is proud to launch the Faces of Ability Project Part 2, Mental Health Resilience. We are very excited to begin this open discussion and process of demystifying and destigmatizing mental health struggles, challenges, and issues that we face both personally and as a community. As you may remember, in July 2018, UCSF launched the Faces of Ability project in their own words, which highlighted and showed people with a variety of unique challenges and abilities with the purpose of destigmatizing and sharing the experience of living and working with a disability. In addition, it was designed to illustrate that UCSF strives to be a culture that is fully inclusive and embraces people with disabilities. The overwhelming success and positive feedback of the Faces of Ability project was and is the impetus for the Faces of Ability Part 2 project, focusing on living and working with mental health challenges. There will be future Faces of Ability Parts 3, 4, 5, etc., that will focus and highlight on living with other areas of disability, conditions, and challenges. While we are all successful members at one of the top academic and medical health sciences institutions in the world, at some point in time, you may have also felt the stigma attached to mental health. Disability, and specifically mental health challenges, touches and or will touch many of us at some point in our lives. It is essential that we continue our work to educate and enlighten our community of current and future healthcare providers, faculty, staff, and learners to be informed and compassionate in providing the best healthcare for our community, and that must include mental health. Americans with Disabilities Act is 30 years old this year. And while we have made tremendous strides in accessibility and inclusion, mental health continues to be kept in the shadows, continues to be a source of fear and shame, and just not openly acknowledged. The time is long overdue to change that, and UCSF must lead the way. We hope this project helps begin that change. Our values define how we work, learn, interact, and fulfill our mission. The UCSF Pride values are the cornerstone of everything we do, and they unite our faculty, learners, caregivers, staff, and community in building a culture of collaboration that inspires us to be our best today and in the future. The committee's goal is to foster a shift from stigma towards a culture of openly discussing and seeking support, acceptance, and inclusion for those who live with mental health challenges. We will be providing programming during the course of the next year, but please feel free to reach out to us if you would like to share your stories, collaborate with us in programming with your school, department, or group, or to share other ideas and suggestions. Mental health touches us everywhere, so there is plenty of opportunity to address the intersectionality of mental health with many other groups. Again, we encourage you to please visit our website to view the participant posters and profiles with quotes as well as the video stories, and we will be adding more stories as the year progresses. Thanks again, and now I will turn this over to Dr. Stephen Hinshaw.
All right, thanks, Tim. It's great to be here. I'm going to do the quickest chalk talk mini lecture on stigma and mental illness that I've ever given to kind of kick us off today. So let's go to the next slide, please. What does this term stigma mean? Everybody talks about it. Literally, back in ancient Greece and Rome, stigma referred to the brand, the mark burned into your skin if you were a member of a devalued group. At the Agora in Athens, if you're an Athenian citizen, you might have wanted to know who had fought for Sparta, who was a former slave, and that person was branded. Most branding we do today is psychological rather than physical. Now, Hitler did brand people in concentration camps, including people with mental and intellectual disabilities. Some countries on our planet branded HIV positive individuals in the 80s so that everybody knew to keep away. But most stigma today isn't a physical mark, it's a psychological mark of shame. As you can see in the middle of this kind of text-heavy slide, many different groups receive stigma. One of the interesting things about this list is, well, left-handedness. When I was growing up, my grandmother didn't want my little sister to be left-handed. Sinister terms like this refer to left-handedness. Today, if you're left-handed, you have good spatial abilities, maybe you'll get into MIT. It's not a bad thing at all. As social norms and mores change, traits that were formerly stigmatized may be far less so. However, among the many conditions and traits here, and many more exist too, people with mental disorders, people who are homeless, and people who abuse substances, even in public attitude surveys where people admit to what their liking or disliking is, these people are at the lowest of the low. These are the highest rates of stigma we know of. We haven't seen the secular trends in gay marriage attitudes, which have improved markedly across the last 16 years in our country. Attitudes toward mental illness have essentially remained flat over the last 60 years, although I think we're on the brink of change. So we'll go to the next slide quickly. Wrote a book on stigma and mental health issues 13 years ago. I think it's time for a second edition if I can free up time. First book in the English language. It wasn't an edited book with different authors, a single authored book on this topic. I chose for the cover art Hieronymus Bosch's The Extraction of the Stone of Madness. In Holland in the late 15th century, mental illness was thought to be caused by a stone in your head. So we see the surgeon, but it's a surgeon wizard, so we know things are difficult here. Extracting not a stone, however, from the patient's head, but a flower. You can see the little white tufts. The name for mental illness in Holland back at that time was, you were called a tulip head. So Bosch was sardonically painting that if you remove the tulip, remove the label, would that cure the mental illness? Or would it be a source of stigma? Next slide, please. So it was thought half a century ago that a few of us are raised to become bigots or stigmatizers. The view is radically different today from both evolutionary psychology and social psychology. All of us are hardwired in many ways to stereotype the large groups of people we interact with, or at least we used to interact with, not on Zoom calls before the pandemic. But if we don't like some of the people in that group we stereotype, that's prejudice, where emotion comes in. And then the tendency would be to discriminate. I'm a Cal Berkeley and a UCSF professor. Of course, I've never stereotyped in my life except against Stanford individuals who wear red and go to private schools. And so I don't like Stanford very much. There are arch rivals, and I don't let any Stanford students in my class for extra credit or to take it online. Maybe we are wired as humans in part to be wary of people who are contagious, big issue in the time of COVID, who may cheat us or have low social capital, or who look and act so different from us, they seem to be almost part of a different tribe. So stigma comprises all of these elements, but if I stigmatize you and the group you belong to, everything about you is part of your group membership. You've lost your individuality. And we know that stigma has been used by despots throughout history to not only put down a group, but to expel or even exterminate certain highly disfavored outgroups. So let's move ahead. Next slide, please. So what's the evidence? Too many words on this slide. Study after study after study over the last 50, 60 years. People don't want to be very close with people who show symptoms of or get the label of mental illness in all its various forms. More recent studies over the last 20 years that don't rely on attitude surveys, 1 to 7 scales, but try to get at your less consciously expressed opinions, show perhaps even more stigma. So maybe we're just at the tip of the iceberg. Also, if we were anthropologists for a second, we'd realize that in half of our states in 2020, right now, if you admit to having a mental illness, you can't renew your driver's license, you can't vote, serve on a jury, run for office, and you pretty much automatically lose custody of your kids. Classic evidence for discrimination. Media portrayals of mental disorders, certainly there's more human interest in better stories now, but the predominant images are still of violence and incompetence. Next slide, please. So we have 2 more busy slides. If stigma exists against the group, it's likely, although not inevitable, that members of that group will know the stereotypes and prejudices and come to internalize it, show self-stigma. This is very important in the realm of mental disorder. Over and above the symptoms of depression I might have, if I also exhibit self-stigma, I'm not very likely to get into treatment, or I drop out early if I do. So there are structural barriers against treatment, of course, but at a psychological level, I may not even feel I deserve it. So reducing stigma and self-stigma are crucial targets. Next slide. And then a further term used by Irving Goffman, the sociologist who ended his career at Berkeley several decades ago, said in his classic book on stigma in 1963, called Stigma, Notes on the Development of Spoiled Identity. Goffman said, if society bothers to stigmatize me, and because of the group I'm in, it's only common courtesy for society to stigmatize anybody around me, like my family. And in the case of mental disorder, for much of the history of psychology and psychiatry, families were blamed even more because they had caused autism by being refrigerator parents, or the mother who was schizophrenic had caused schizophrenia because of her cold, hostile, aloof style. So families are doubly blamed. Who else gets in the shadow of what we call this courtesy stigma or associated stigma? People like me, a clinical psychologist who works with and does research on kids with ADHD and other conditions. I mean, we work with people who are disturbed or crazy. I'm being very slangy in my language here. Professionals are viewed by too many people with serious forms of mental disorder as the source of stigma, as opposed to often the source of care, because of the low expectations, because clients and patients get the sense that they're not worthy of the same care that somebody with a physical illness would cause. And I think this behooves us to look at our own training models in nursing, social work, psychology, psychiatry, to really remove the stigma. Next slide, please. So all of this is a bit of the science of stigma. I'm interested in stigma for very scientific reasons and very personal reasons. My latest book that came out 3 years ago, Another Kind of Madness. Here's my dad, a philosophy professor at Ohio State, and me at age 18. You can notice the mustache and the hairdo back in the day in the 70s. This was just 2 months after I first came back from my spring break, freshman year in college, from back east back to Ohio, and Dad had pulled me aside in his study to talk about why he'd been absent so much when I was a kid. We'll go to the next slide. There's a couple of talking points. He was gone for 3 months, 6 months, at one point, a year at a time. And my little sister and I had no idea where he was, if he was alive or dead. What I didn't know is that my dad's lead doctor had told him and my mother that if my sister and I, Sally and I, ever learned of his mental illness, which was thought to be chronic schizophrenia, turned out to be bipolar disorder, we'd be permanently destroyed because the issue was so toxic. So a generation or two ago, in the 50s and 60s, the doctor's orders were never talk about mental illness in a family. The kids will be permanently destroyed. Once I got wind of what was really going on in my mysterious family, I changed my major to psychology and clinical psychology, went into the field to both work with kids and families, do research on causes and treatments for mental disorder, and now, through my writing and research and advocacy, fight the stigma that still exists. My dad had genetic vulnerability. He'd lost his biological mother when he was 3. He was abused by his stepmother. There's many roots to severe mental illness, both biological and psychosocial. My dad told me right before he passed away that he'd often wished he'd had cancer through his life. And I thought maybe he was having another episode, but he said, I'm a philosopher, son. Mental illness means to people like me that it's imaginary. If I'd only had cancer, a real illness, maybe I could have forgiven myself for all my episodes. And I thought I knew something about psychology. Mom, her last 40 years from age 50 to 90 were spent in the throes of very severe rheumatoid arthritis. Undoubtedly, her immune system went into overdrive from having to cover for the silent family in the Midwest, whose appearances had to be kept up by doctor's orders and not admitting the most important issue in their lives. So final slide. So stigma's real. It has terrible consequences. Stigma is worse than any form of mental disorder per se, because we can treat mental disorder. We can't cure it yet. We can't cure cancer yet, but we can treat it and people can recover. It's really important for people to talk about these issues, not just do science on them. Certainly treatment's an important aspect. And of course, to reduce stigma, we're going to have to enforce the Americans with Disabilities Act, enforce parity for mental health coverage as well as physical disorders, physical illnesses, change media images. People getting evidence-based care is probably the biggest anti-stigma thing we can do, but access is not what it should be. And most of all, as I just said, disclose, discuss, to humanize. Cancer was a very shameful illness in the 30s, 40s, 50s, and 60s. Everybody knew it was a psychosomatic illness you brought on yourself. Cancer is now a cause. We know it's an underlying biological thing. And now we have the NFL dudes wearing pink knee socks a couple of Sundays this fall to fight breast cancer. We don't know what color knee socks the athletes are going to wear to fight mental health because we're not there yet, but I think we can get there. So thanks for listening for just a taste of my personal and family story, a mini lecture on stigma, and we're going to transition to Jean right now, who's going to talk more about the faces of ability.
Okay, thank you, Steve, and thank you for your message that you just left us with. I'm Jean Stanford. I'm a psychologist and the director of mental health services at Student Health and Counseling, and I'm going to be really talking about the student perspective. Next slide, please. I just wanted to give you a little bit of an overview. So our mission at Student Health is to help students with their physical and mental health in support of their academic success. And because of that, I think we're located in student academic affairs, which I also think helps to reduce the stigma involved. So I do have a little bit more hope than Steve was just conveying. Next slide, please. In terms of the scope of services that we do, I think it's particularly important that we're co-located with primary care, which also reduces the stigma in terms of coming in for services. So we do have a comprehensive service in terms of primary care, counseling, psychiatry, health education, and promotion. And we do a lot of consulting with faculty and staff. Again, all things that help address and help students to come in for services. The next slide, please. I wanted to show this. This slide shows us that there has been an increasing demand. So I know I'm kind of going against the stigma that we're talking about, but I'm going to come back to that as well. We have seen a 40% increase in demand for services over the last 5 years. And then we see about a quarter of the students typically during any given year. In the pandemic, at this point in June, we had 25% more visits than we had in 2019. In July, we were up 43% more visits. And in August, we went to 21%. Again, I think that really speaks to the kinds of outreach we do, the kinds of comprehensive services we do have at a counseling center that is located on a university campus. Next slide. Now, I wanted to show this in relation to the presenting concerns, and these are pre-COVID, right? So pre-COVID, anxiety and depression always sort of flip-flopped, not just at UCSF, but across the country. What is unusual for at least the UCs is number 3 being our next presenting concern here at UCSF. So pre-COVID, we'd be talking about sexual assault or child abuse concerns or financial trauma and some racial trauma. But during COVID, because we are a health profession campus, we've seen basically COVID anxiety in terms of not only the students' own health, but the health of their loved ones and going into the clinics and hospitals. So fear of that. We've seen the politics influence people's trauma in terms of coming in. Then the Black Lives Matter and the stressors for Black and Indigenous people of color. Early on in the pandemic, you might remember the xenophobia and the Asian bashing. So that brought students in as well. In terms of the racism and injustice and police brutality, that's continuing to bring people in during the pandemic. And then the disparities that have been talked about as the racial disparities. So we've had students sheltering in place 6 to 7 to a 1-bedroom apartment. And then we also have students sheltering in place, just 2 or 3 of them or with their parents in a 4-bedroom house. So again, those disparities. And sometimes that can cause stigma in terms of people not wanting to admit that. But we found that when you have people that look like the people that you want to come in, you have people of color as clinicians, the students are more likely to come in. And again, because we're located with student academic programs, we're talking about success in terms of when you want to come in for therapy. Next slide, please. So how do we address this? Not only do we have BIPOC clinicians, including myself, we look at students holistically. We do try to use this wellness wheel. We encourage students to look at all aspects of their life, not just their mental health, but to really be balanced and well-rounded in their approach to mental health. So we take a holistic approach. And then next slide, just want to leave you with a word cloud and, in terms of healing and calming and giving us all hope. And I'm happy to answer questions later. And I want to turn this over to Diane.
Hi, everyone. My name is Diane Noe, and I'm a staff here on campus at UCSF. I currently work as a program manager in the Department of Surgery. And I'm really honored to be a part of this panel and just really honored to be a part of this campaign. I wanted to share my personal journey with mental health. And I think for those that know me, this may come as a shock because generally I'm a pretty outgoing, very, cheerful, sunny person. But behind the scenes, I've had just a real journey with mental illness. And it started when I was 19, my first year in college. And I spiraled into an episode of depression and anxiety my first quarter. And I didn't know what was going on. I went home that weekend to kind of just take a break. And I started just getting really anxious because I wasn't doing well as I expected in school. And it just, was just a huge pressure and a huge change just going from high school to college and being away from home. And so I actually spiraled and attempted suicide. And it was just devastating for my family and just was shocking to myself. I had to pull out of school for that year and really just try to figure out what was going on. Just being Asian American and Asian in general, our culture is, one where we don't share publicly our struggles. And there, like Dr. Hinshaw shared earlier, there's a lot of stigma towards mental illness. And so my parents didn't know what to do, and they wanted to protect me. And so we didn't really seek help after I was healed from just that traumatic experience. So this continued. I went back to school again the year after, and I just went in and out of depression for just several years, well, actually like for a decade, until another episode happened. And all this time, never shared with friends, just with my family members, close family members. And so it was just something that was like just this very shameful thing that we carried with us. And not until 2008 did I had another episode. It was so severe, I had to take time off of work, that I actually was recommended to go see a psychiatrist. And during that time, we went through our just kind of the history track, and she finally diagnosed me not just with depression and anxiety, but bipolar depression, which was very shocking to me, because I think just the term bipolar carries such a negative connotation with it, and I just felt so helpless. On top of just dealing with this, I already I'm a polio survivor, so I live with a physical disability. So that's already something that I had to carry and had to figure out. And having this additional disability on top of it was just so heavy for me to deal with. But I went and I sought the right care. She gave me medication to really help me. And just looking at my overall just history and background, being a refugee, having had just 7 surgeries as a child, all this trauma to my central nervous system, just being a polio survivor, and just everyday living, and so that all that makes sense. Dr. Hinshaw mentioned earlier, there's many reasons and there are many factors that can play into mental illness. And so it's not just one thing, and it's not my fault, but all the while I felt it was my fault. I felt it's something I could control. And again, that's a myth. And but even then, after I sought the right help back in 2008, 2009, I felt better and I stopped taking medication. And I just felt like, okay, I think I've got this. And again, I still hadn't shared with any friends outside of my family. And not until 2014, when I started seeing the signs of me not being able to sleep again and having anxiety, did I finally felt that I could actually reach out. And it was through my relationship with my pastor and my faith that really sought me to finally not punish myself and really, really embrace, like, this is a part of who I am. And it's not, a shameful thing. It's actually just how God has wired me. And I can actually, there's help, there's medication. And I was very diligent, and I decided to really take better care of myself, changed my diet, started exercising, and then sharing with friends, just close friends, just sharing and getting the support that I need emotionally, and just through prayer, and then going to counseling and really talking with a professional to just deal with, how do I now build a toolkit of how I can help myself, that when I face these ups and downs, that I can actually have resources at my disposal. And so I really wanted to share my story, because I really wanted to just encourage anyone out there that is dealing with challenges, that to know that you're not alone. Because as I shared my story, other people shared theirs as well too. And it just kind of brought this amazing bridge of healing that I don't think that I would have experienced had I not just made myself vulnerable and sought the help that I needed. And so if there are people out there, if those of you out there watching this or knowing someone that has gone through something like this, there are resources we're going to share about that in this presentation and on our website, and that you can utilize, and just to know that, you don't have to suffer in silence. And so that is my personal journey. I'm happy to answer any questions as well at the end of the presentation. And I'm going to hand it over to Montgomery.
Thanks so much, Diane, and thanks for sharing your story. What an incredible story. Hi, everyone, again, and thanks for attending our presentation today. My name is Tim Montgomery, for those who weren't on at the beginning. And I want to share a little bit of my journey with mental health challenges, both from a professional perspective as well as a personal perspective. As a professional, I've worked with learners for almost 39 years, the last 20 or so in higher education, who have lived with various mental health challenges and struggles. While we have tremendously improved our methods and understanding of diagnosis and treatments, our learners and communities still struggle with stigma, fear of not being given opportunities, retaliation, and being negatively judged due to their diagnosis. If UCSF is going to continue to lead the world in advancing health worldwide, we must openly include addressing and accepting mental health needs and struggles as part of that advancement. And we must allow our learners and community, excuse me, to openly discuss and seek treatment for their mental health needs, allow our learners to hear from faculty, staff, and leadership about how they address their mental health needs, and prepare them for addressing their own mental health as future world-class providers. This must be done for everyone with complete and open acceptance and without fear, shame, or judgment. On a personal level, I was diagnosed with major depressive disorder in the early to mid 1990s. And while that was a new diagnosis for me at that time, looking back, I learned and realized that I had lived with undiagnosed depression most of my life. I lived for years in denial and just not addressing it, with what I realized today was self-medicating and dismissing it as something I needed help with and just tried to overcome it myself. Looking back, it was out of fear and shame and feeling like I was not good enough or strong enough to handle it myself. It was also a time when the onset of my arthritis began, and I lived for about 20 years with severe and chronic pain. And in the late 1990s, I experienced a 7-month period where 3 traumatic and negative life events happened to me. All of this took its toll on me physically, emotionally, impacting my relationships and family, but I still did not reach out for help. I was afraid and embarrassed and did not want anyone to know. I felt if I tried harder, I could handle it myself. I functionally struggled through life until about 2011, when I finally reached out and found a life-changing therapist and began to take medication for both my depression and arthritis that I could tolerate. I was finally addressing my emotional, psychological, and physical needs and was pain-free in many ways for the first time in about 25 years. I stopped self-medicating and started living a much healthier and positive life. My journey continues each day, and I am mindful that I still struggle with isolation and withdrawing when my depression impacts me. But I hope my story will encourage others to not wait to seek help. Please make your mental health a priority. I also hope we can create a safe space here at UCSF for everyone to be able to share their stories and feel acceptance and strength from each other. We hope you view and gain some strength and encouragement from our participant profiles, but also know we had several people contact us to share their enthusiasm for this project, but yet did not want to participate because of fear. That climate needs to change. And one final comment, I really want everyone to be mindful that everyone's mental health experiences are unique to them. And while there may be some similarities, you may relate to parts of my story or parts of Diane's story, it's going to be unique to each person. And to please take care to not automatically predetermine what someone can or cannot do because of their diagnosis. Thanks again so much. And now I will turn this over to Christina.
Hi, everybody, and thanks so much. I'm just so deeply grateful for Tim and Diane for organizing Faces of Ability too, but also both of you sharing your stories so openly with all of us. I mean, Steve did get a really rapid chalk talk about mental health stigma, and it's clear that us talking about this openly is one of the strategies that can help reduce the mental health stigma. So I'm just really grateful for you and delighted to be here. My name is Christina Manguri, and I'm a professor and vice chair in the Department of Psychiatry. I'm a psychiatrist, And today I'm going to talk to you guys about some resources that are available to you through the UCSF COPE program. It's the Employee Coping and Resilience Program. Next slide. So it's so serendipitous that this is actually happening right now. As Jean said, there's so much COVID anxiety. This is a slide that was created by Victor Sang, a pulmonologist, very early on in the pandemic. And the pandemic, we know, has the purple line has changed and isn't exactly as we see it now. But the red line of the psychic trauma, the mental illness, economic injury, and burnout is pretty accurate. We're all so exhausted, and this has been so challenging for our community. Next slide. They've done many different studies to try to examine kind of populations at risk. For those of you who haven't seen this, there's something called Lit COVID, which is a curated literature hub tracking up-to-date scientific information about the coronavirus 19. And it has tons of articles, and you can see in the graphs, you can see the weekly number of publications when I just type in psychological impact right in here. And there's actually showing how many publications are coming out across the country. And what a couple of systematic reviews and meta-analyses have found that were published in BMJ and other journals is that these are the populations that appear to be most affected: women, younger populations, people of lower socioeconomic status, frontline providers, those at high risk of contracting COVID, those who are socially isolated, and caregivers. And many of you in the audience are probably seeing yourself in here, or maybe multiple identities that you might have that would put you at risk. Next slide. So today I'm going to talk to you, as I mentioned, about this program. And what I love about this program is that it's really a program for everyone. One of my major roles in the Department of Psychiatry is the Vice Chair for Diversity and Health Equity. And this is a program for everybody, all employees, regardless of your role. So you can be faculty, staff, or trainee. And so everybody can get the treatment they deserve, whether it's individual treatment, non-treatment groups, or self-help. Next slide. So for individual help, everyone can visit this website, or actually also text 83973. And for some reason, I think some of the slide got changed. So I'm going to put this in the chat to everyone. This is the other, what you can text. And so to utilize the program, you can go to this URL, and it'll actually put you through a bot, which triages you to the care that you need. This whole program was developed by Dr. Maja Jackson-Trish, and she took a population health approach and realized some people are going to need urgent emergent care and need to call 911 if they feel it to be a danger to self or others. Other people have pre-existing conditions and need to be reconnected to their providers or get connected to a provider very quickly. Others have new emergent symptoms. And then there's many who maybe just need self-help resources. But this link will help you get there. We've had 25,000 people have accessed the chatbot. Almost 2,000 have answered one or more questions. In our community at UCSF, 26 people have been referred to 911, and 11 found that they had self or child endangerment, and 370 were referred to behavioral health assessment, and about 250 of them initiated treatment. Next slide. I've also been working on a lot of the well-being efforts. And so again, I think there's some of this, oh, it's the prior slide, I'm sorry. No, one got deleted, I guess. There was one about the different special interventions. Oh, there it is, some special interventions, but the special interventions doesn't have all the, oh, there's the content. So there are a few different things that you can get through this that we have. We have well-being town halls, we have resilience small groups, and wellness workshops. So these are things that are available to you on a unit. So let's say you belong to OB-GYN department, your department or your division could request some. You can go to this website and fill out a survey. We've delivered these special interventions to over 50 departments or divisions or units across the university. The town halls have been really helpful. In the new year, we're probably going to move to a new model and just have kind of university-wide sessions that'll be held that will be open. And this has been really led by my colleague, Margot Pumar. And then if we can go to this slide with that pretty picture on it with the family, next one before, I think, sorry, somehow got that one. Okay, so there's part of this that's missing, but this is this website, this link, I recommend that everybody go there. This is a robust website in the Department of Psychiatry, and it is just has curated free mental health apps. And then it has special things like how to deal with the wildfires, how to deal with election stress, how to, you know, if you're pregnant and concerned. I'm putting the link on here for everybody to see so you can go there. How to care for, you know, resources for caring for children or loved ones, etc. There's also a lot of videos and webinars that are really helpful for stress reduction strategies. Over 100, close to 200,000 people have visited the website, and 15,000 have viewed these videos, and almost 50,000 have viewed the webinars. So I highly recommend it. I recommend it to my patients. I recommend it to my colleagues and my friends and family. So take advantage of it. And given today we're talking about stigma, I'm also just sharing the link for some of the discussions about stigma, because you know, we could stop the slides. I lead a lot of the mental health efforts for these well-being town halls, and never before in my professional career do I do so much self-disclosure about the fact that I too have struggled with mental illness, and I've had postpartum depression and some anxiety and taken Lexapro. But I say that in these settings very intentionally, to reduce stigma, because right now people are having such a hard time. I want them to know, look, a lot of us may go to a therapist and seek psychotherapy or take medications. And if that's right for you, you know, when you make the decision with your provider, please do it, you know. And so I'm just providing a little bit of the resources about stigma there. So I think now we can take off the slide, because I don't think there's anything we need to see with the slides. We can just turn to some questions that I have for the panelists here. And if there's any questions that people in the audience have, please let us know. We're going to be talking for about 10 minutes. So the first question I have for you all is, what systemic or institutional changes would you like to see at UCSF to reduce stigma so people aren't afraid to disclose or speak about their struggles? Who would like to go first?
Well, I'll start just because to get the ball rolling. I'm going to go beyond UCSF to the Americans with Disabilities Act, which, as Tim, I believe, mentioned, celebrated its 30th anniversary this past July. And it outlaws in the United States discrimination against people with mental or physical abilities in public or in the workplace. The vast majority of suits brought against employers in particular under the auspices of ADA emanate from people with physical disabilities. There are more people, many more people with mental disorders in our country than physical disabilities. The average cost of an accommodation under suit against, under the auspices of ADA is a ramp or a doorway. It's quite expensive. The average cost of an accommodation for someone with a mental disorder is work over lunch or work an extra hour and see your shrink over lunch, and it doesn't cost you anything. But people are too ashamed because of the stigma to bring it up. So it's an example of policies are good. Parity is a highly desirable goal, but any institution, whether it's the federal government or UCSF or anywhere else, has to create a culture where it's okay to talk about it. You may not raise your mental disorder in a job interview because you don't have that job yet. You're not protected under ADA. But once you have it, especially at a large organization with a good HR department where you can speak initially in confidence and get advice, disclosures about timing and support and rehearsal. I don't wear a sandwich board when I walk through the Berkeley campus, which I haven't for a while now, that says, Dad had bipolar disorder, I've had depressions, and I made my throw up in college because I was so scared I'd go to a mental hospital. But I choose when to say it when I've got the right support, as Christina, you just said, and Diane, you just said, and as Tim, you just said. So we need structural supports, and we also need to create a culture where disclosure is acceptable. It's not a sign of weakness to ask for help, it's a sign of strength. That's probably the most important message I think I could give.
Yeah, I'm almost wondering whether there should be like, and I don't know, perhaps there is already, but on HR, when everybody's onboarded, for them almost to be informed that now you have this job, if there are any, very explicit, if there are any physical or mental health disabilities that you'd like to talk to your HR representative about this, you can do this, confidentially. I'm not sure whether that is actually how it, because I do think people are worried about being stigmatized and losing their jobs.
I think it would be
Making it
worth
very clear.
a deep dive, Christina, into what can and can't be done during
Right.
the onboarding, right?
Right, exactly.
Yeah.
What about others on the college? What things would you wish we could do? What changes, institutional systemic changes?
This is Tim. I'm going to answer this from the perspective of the students that I work with. And I think the number one thing they would love to see and hear is what I spoke about, is their faculty and the administration of their schools and programs to build a mental health unit into each course, into each clerkship, into each clinical experience. And it doesn't have to be a big production, but in every class, give 3 or 4 mental health moments, a minute, where they can just turn off their camera, turn off their microphone, and breathe deep or visualize or give themselves some affirmations. I think saying it out loud provides power and it makes it real. And when you do that, then it becomes real for everyone to say, yes, mental health matters and mental health is important. Another suggestion people had was, through HR, we have sick days and we have vacation days. We don't have anything for mental health days. And if you take a mental health day, it's really, you turn around and take a sick day, which really associates it with kind of a negative connotation. So even having a number of days set aside for mental health needs or mental health break. And then the final thing is, our supervisors encourage your staff to block off mental health time each day, even if it's a half an hour each day. Block it off. That's your time. That's your mental health time. Take good care of yourself. And just some simple things. And saying mental health needs, taking care of your mental health out loud is so powerful.
Yeah.
Mm-hmm. I totally agree with what Tim just said, and I was going to say the mental health days as well. I've heard that from students as well as from myself. I don't think it's fair that we have to take a sick day for mental health, but you're also speaking to the culture. So one of the things I wanted to say was, besides from ending systemic racism and oppression for all the groups that have been talked about, because it's not necessarily always coming internally, right? It's our climate and the structural oppression that we have. But if we could, the culture here at UCSF and in many places is more. I'm not enough unless I do, I'm not good enough unless I do more. So until we change that culture, we have to talk about balance or at least figuring it out, right? And part of this is, part of the stigma is, if I admit that I need a day off or this is too much for me, then I'm not good enough, right, to be here. And so I think changing the systemic way of changing that culture and climate would be really important and go a long way, I think, towards reducing mental health stigma. And that thrive for perfectionism, we just can't be perfect every single day.
And I think inherent to what you're saying, I mean, like, I think we have an opportunity right now with COVID that's forcing us to do certain things, like, that all of us are under so much stress that, making meetings to be a little bit shorter and shorter and addressing well-being. But I think a lot of it has to do with the role modeling, and a lot of it has to do with really high up leaders. And I do think that I remember there was a campaign many years ago, early on when I returned back to UCSF, that was said, how do I take care of myself? There was a well-being effort that was at the university, and it had a lot of pictures of leaders. But everything they were saying to promote their well-being was exercising, diet, going to church. Nobody said anything about going to therapy, taking medicines. And I remember feeling really like that was a missed opportunity. And I'd love a repeat of that effort again, but more with some self-disclosure, because I think I'm going to get at a question that sometimes I think there's a yearning that the staff and trainees and those kind of moving up in the field want to see that there are people like them, and that doesn't mean you can't succeed. It's not true. Diane, did you want to add anything about the structure before I take the next question?
No, I think everybody said everything that I would share. So we can move to the next question.
Okay, it's a related one. Now, I think that there's a good question by somebody in the audience who said, many of us are not in leadership positions of power. And then they say parentheses yet, because I think this person will be someday. And thus they feel that while sharing our mental health experience could be empowering to others, it will likely negatively affect our competitiveness in training, professional, and grant opportunities due to stigma. How do we navigate this? So this is a young person, I'm making it up. Let's say they're a trainee, there's a student, and they're like, do I share that I have had a major depression? Will that impact my chances of getting into med school or residency or get a grant? So I'll turn that over to, should we go in the same order? Steve, do you have thoughts? Oh, you're on mute.
Most people want to mute me a lot, but I have to unmute myself. So let me go to other panelists who didn't speak before, because I would have a lot to say, but we're running out of time.
We are.
Well, I'll just say this. I think we have to be wise in terms of when and who we disclose to. If you have a concern about that, it might have a negative impact to your career, to the grant that you're working on per se, then I would definitely hold. I think what we're trying to share is that if you need help, we definitely encourage you to seek it, but seek it in a way that's not going to adversely affect you. Yep. And that there are anonymous resources out there. And then also that, it's really to build this community and to build a conversation to normalizing the challenges that we go through. I think that's really key. And that's really the heart of this campaign and why we're doing this panel, that this would be really the jumping off point that we can then see if everyone is coming together and wanting to support each other. I think we will get to a place. That's my hope. And I think that's everyone's hope here, that we will get to a place where that fear no longer exists down the road. So hopefully that will come sooner than later.
And Diane, I know we're at the point when I'm supposed to end it, but I would just echo, unfortunately, I don't think we're at a time yet. We're not quite at that place yet where this can be totally free of an adverse impact. I wish I didn't have to say that.
Can I just add one thing real quick? I'm sorry, Jean. As I said earlier, way in the beginning, we are going to be doing programming throughout the year. So whoever posted that question, if you would please like to reach out to me, we can confidentially connect. And that'd be a perfect, I think, idea for programming or a topic.
Yes. I love that. And also making it so that residencies actually maybe are more inclusive. That's what I do in my fellowship. Say, I'm very open to accepting people with lived experience. And this is part of the diversity of our, our student body. So I'm just saying it's very complicated still.
Mm-hmm. And I was just going to say, find someone you trust first. It's always take the first step with someone you trust, and then you can move on from there.
Well said. I'm going to wrap this up. Thank you so much to all of our panelists and those that shared questions, and everyone that's attending today. We have our website, as we shared in the beginning. Here's our website. It's at Diversity and Mental Health Resilience. And we here at the website, this panel discussion is recorded, so the video will be available soon. Also along, you'll see we had interview with people that wanted to share their stories. And you'll see there under the people screen tab in the bottom left-hand corner. And then we also have videos that we're going to be sharing, like just personal testimonies throughout the year that we'll be posting onto the website as well. And there's also a toolkit as well available at the website. If you want to share your own personal stories, there's ways that you can do that and ways that you can partner with us as well. So we just really wanted to thank you for coming today. And we just hope that this is the beginning of much more conversation. And all of us on the panel are available if you want to reach out to us personally and have any questions, follow-up questions and whatnot. So big shout out again to Kim Lipien for all of her work, and our IT folks as well, Ben and his team, and our caption analysts as well. So thank you so much. And we hope that this is the beginning of more conversations to come. Take care, everyone.